Hello, it's a pleasure to be here today at the FIGO World Congress. My name is Amy Pollack, and I'm the Senior Director for Maternal, Newborn, and Child Health, Family Planning, and Nutrition at the Bill and Melinda Gates Foundation. I want to thank the FIGO organizers for making this event possible, and I'm honored to share my thoughts on the critical role of that nutrition plays in improving the well-being of mothers and children. Our approach to maternal health at the Gates Foundation has evolved significantly over the last few years. We have now integrated maternal nutrition within our MNCH strategy to accelerate thinking and implementation of the highest impact solutions. Maternal nutrition is the underlying cause of 1 in 5 maternal deaths, with anemia as the leading cause of maternal deaths, most often due to obstetric hemorrhage postpartum. Maternal malnutrition increases the risks of stillbirths, perinatal mortality, low birth weight, preterm birth, and congenital anomalies such as neural tube defects. Maternal anemia is associated with altered and delayed pre- and postnatal neurogenesis and myelination and impaired intellectual development. Today, I'll be focused primarily on the importance of integrating maternal nutrition in health services, but it's critical that we also consider how to reach women before they become pregnant, as I will explain. Women often enter pregnancy with nutrient deficiencies, and in addition, access ANC services too late and too infrequently for interventions to realize their full potential. Anemic women enter pregnancy with inadequate iron stores to support the increased demand for iron required to develop the fetus and the placenta in the context of pregnancy-related expanded maternal blood volume. Many women, particularly in low and middle income countries, start taking iron and folic acid supplements when their pregnancy is first socially recognized, but a first ANC visit is most commonly in low resource settings at 16 weeks, and this is too late to avoid many adverse outcomes. Starting pregnancy with adequate iron and folate stores can make a big difference. Folic acid supplementation around the time of conception significantly reduces the incidence of neural tube defects, but when it begins after the first trimester of pregnancy, it's too late for prevention. Addressing anemia and other nutrient deficiencies before pregnancy makes the biggest overall impact for several reasons, including the establishment of habits that need to continue throughout the pregnancy for full impact. Strong health systems and communities are absolutely essential. If OBGYNs, midwives, nurses, and community health workers aren't factoring maternal nutrition into their antenatal care, it probably means that maternal nutrition interventions aren't getting delivered. You've heard from other speakers today about the benefits of multiple micronutrient supplements, or MMS. Designed specifically for pregnant women, it's a cost-effective and proven intervention that can impact maternal health and birth outcomes for mothers and babies everywhere beyond just iron and folic acid supplementation. In Bangladesh, for example, it's estimated that replacing iron folic acid supplements with MMS could avert over 7,600 deaths resulting from stillbirths and infant mortality, and 16,000 cases of preterm birth annually. So I'd like to focus on a few policies and practices that need to be put in place to effectively deliver maternal nutrition interventions through the health system. First, at the top, ministries of health and their directorates at national and subnational levels are critical to setting national health policy. This can ensure maternal nutrition interventions like MMS are owned and delivered in the health system. Better antenatal care platforms to deliver maternal nutrition interventions are critical. For example, our partner Alive and Thrive, in partnership with the government of Bangladesh and BRAC, integrated maternal nutrition interventions in ANC platforms. The interventions included counseling on healthy eating, including dietary diversity and food quantity, daily oral iron and folic acid supplementation and calcium supplementation, weight measurement, and breastfeeding promotion and support. In a period of just 3 years, the results were pretty astounding. The average number of IF8 tablets consumed during pregnancy increased from 45 to 139 tablets. The average number of calcium tablets consumed during pregnancy increased from 60 to 145 tablets. Weight measurement increased from 38% to 98%, making malnutrition an early indication of the need for an intervention. as noted by weight measurement, and exclusive breastfeeding practices increased by 30 percentage points overall to 78% of mothers. Bangladesh is now in the process of transitioning from IFA to MMS, but the key is that they figured out the systems level changes that are needed to make these kinds of interventions work. The question is how? The answer is that activities both within and beyond the health system helped healthcare providers deliver more and higher quality nutrition support, including helping influencers surrounding the mothers, including fathers and community leaders, play a more active role and supportive role throughout their pregnancies. For healthcare providers, improved timeliness and quality of ANC contacts were encouraged through targeted interventions such as feasible caseload allocation, home visits used to deliver ANC, thereby reducing logistics and transportation needs, were another intervention. This work will look different from one country to the next, but the common thread is that healthcare providers can't possibly deliver high-quality nutrition interventions if they aren't supported to do so. Alive and Thrive has developed a framework for implementing maternal nutrition programs at scale, which includes 4 key programmatic components: interpersonal communication and community mobilization to improve awareness, confidence, and skills of both pre-pregnant and pregnant women; advocacy for supportive policies at the national, district, and sub-district levels that raise the priority of maternal nutrition; mass communication to reinforce messages for mothers and frontline workers and to involve families and social influencers through public awareness; and lastly, strategic use of data to track the progress of intervention delivery and impact on coverage and practice. We need to make nutrition supplements a social norm throughout a woman's life. But there are other platforms that can be leveraged in addition to this to increase the coverage and impact of maternal nutrition interventions. In Pakistan, we're testing the effectiveness of delivering balanced energy protein supplements, also called BEP, through a national social protection program providing support exclusively and intentionally to women. Among undernourished women, BEP supplements during pregnancy have been shown to increase the weight of babies at birth, decrease stillbirths, and decrease the risk of small for gestational age babies. Finally, I know we all share an acute urgency to introduce and scale maternal nutrition interventions. The COVID-19 pandemic has put the most vulnerable even at greater risk. Without adequate action and within and outside the health system, the profound impact of COVID-19 pandemic on maternal and early life nutrition could have intergenerational consequences for child growth and development, and lifelong impacts on education, chronic disease risks, and overall human capital formation. I look forward to hearing and learning from my fellow presenters and to continuing to partner with many of you to make our vision a reality, that healthy mothers can deliver healthy babies who thrive into childhood and beyond. Thank you for your time.